and this is coming up. And I got a couple of questions on text. And so I will then ask you guys to reply to. Good evening, everybody. This is now live, and I would like to ask the first couple of questions to our panelists. I'm introducing Dr. Nadir Sanai from Barrow and Dr. Albert Kim. And the first question is, what type of applicant are you looking for?
Thanks, Isabel. Well, at the Barrow Fellowship, we want people who are already comfortable in the operating room and in and around brain tumor patients. So we're looking for candidates that are already well-trained and are looking for some polishing from some heightened levels of complexity and want to add some depth to their career, specifically within the realm of clinical trialing, surgical trialing. So for us, it's a very clinically oriented fellowship, and one where we hope the candidates are really aiming high in terms of being real stewards of the field when they leave us.
Thank you. Albert?
Yeah, I would say we also have what I would say, similar to what Nader was saying, is a finishing school in terms of clinical technique, but we really want to build leaders of the future, and it doesn't have to be just like a scientist who does lab stuff. It can also be a trialist. Again, we have some different mechanisms that you could actually apply for instance, phase 0 funding or other types of funding through the Brain Tumor Center. And it could also be innovation or entrepreneurship, which Eric Luthard is very good at. So I think, whatever it is, we want you to be a leader in the field. We want you to bring value to the department that you're going to be part of, and we're going to help you develop that vision.
I have another question here that came through the text messaging, and that is, what attracted you to be a neurosurgical oncologist? If you name the top 3 reasons or 2 reasons of why did you choose this career, what would those be?
Yeah, that's a good question. I think we all come to this from different perspectives. For me, it had a lot to do with, family experiences with neurosurgical oncology combined with strong mentorship during residency at UCSF. And now really the patients and their families motivating me to innovate, to find new answers, and to shepherd them through difficult times in life. So I think it's been, for me in a 15-year career, it's been a constellation of different intersections that have all come together.
Yeah, I would say some of those things are very similar to why I came to surgical neuro-oncology. I would say the patients are probably the main motivating force. I mean, you have something like glioblastoma. We can do those surgeries, we can do them better. But we have to do other things to really create something transformative. And so that's a motivating factor. I would say the surgeries themselves are very fun to do. I think we're still a bit far from the time when we're just going to drop a pill in. I mean, I hope that time comes, but I think it's a great field for open surgery still. And there's a lot of science in the field. And so I genuinely believe that there's going to be more science in our surgery, and that also makes this exciting.
Thank you both. And our third panelist, Nam Tram from Moffitt, is currently in surgery. So we are hoping that he can unscrub, but this is part of real life. Zach, do you have a question?
Yeah, I was curious, and you could both comment because I think you're coming at this from 2 different styles of fellowship as regards a faculty appointment versus not. I'm curious your guys' take. Do you how you think that's either a pro or potentially a con, and advantages, disadvantages of those 2 different styles that we oftentimes see?
Yeah, it's a great question, Zach. I think for us at the Barrow, this fellowship is modeled on the original Spetzler Fellowship, which is something that I completed after training at UCSF. And in that model, you were effectively a member of the private practice. And I thought that it was very instructive in terms of understanding, the intangibles of practice building, practice maintenance that you don't really get exposed to in a residency environment. It really changes your perspective on how you approach your days, your patients, your interactions. And it also gives you some insight into the challenges of working within a private practice environment, which for many graduates is where they're destined. As I mentioned, we're a private-demic environment, really. So it does give you some insight as well into how to combine a private practice environment with an academic ideal.
Yeah, I would say I don't want to say that our fellowship is just like a research-oriented fellowship. The clinical component is very dominant. I mean, I would say that's still 75% of the fellowship. You're a fellow. You're not an instructor with us. You're a fellow, but you'll be doing cases as if you're our colleagues. I would say that's going to give you a lot of experience in the transition to becoming independent. And so it's going to be very case heavy, and it'll be complex cases. The other part of it, I think, is, I think you just really have to think about what value you're going to bring to your department. And that's also the other part that Erica and I want to bring to it. And I'm sure Nader does this also for his fellows, but it's got to be more than just a general ability to do good cases or complex cases. It has to be, well, what is your niche then if it's clinical? Or, okay, you say you can run a lab, well, show me, so you have to learn the specifics of it and to bring real value to your future job.
Thank you both. Dr. Rodriguez, you have a question?
Yes, I know a lot of trainees are always a little bit nervous about the job search. Could you both talk about what you foresee a graduate fellow, what type of jobs are available, or what the landscape would look like, and not just necessarily in academics, if your fellowship prepares people for other options besides academics?
Yeah, no, that's a great question. And in fact, that's one of the reasons we thought that we would have sort of this comprehensive fellowship that incorporates both intrinsic and skull base. I think it's just really hard to get the super specialized jobs. If you can get them, kudos to you, and that's great. But what we were thinking was we wanted to prepare somebody to be able to get any potential great job in neuro-oncology. And so by being able to do all sorts of different types of techniques and also being introduced to the newest technologies, that would give you an edge up in your job search, whether it's private, academic, or private.
Yeah, I agree with Albert. Finding a job, a lot of it is just the circumstances of the moment. We just filled a brain tumor position for junior faculty at the Barrow, and there was an overwhelming response and number of applicants. Our most recent graduate of our fellowship just took a position at University of Michigan, but certainly looked broadly. As Albert mentioned, finding a job is really about conveying your value to a future chair or practice director. And so it's about identity. It's about knowing that you can bring something of value to them and to their program that doesn't exist. I think that's why we work very hard to prepare our fellows with a very specific kind of portfolio of skills that we think are on the rise, but not broadly disseminated. And that really has to do with, clinical trialing and surgical trial investigatorship. So it is very much about being adaptive to the moment. And we try to prepare our fellows for a variety of settings, because you never know what's going to be open, even if you have your heart set on some specific scenario.
Thank you both. I have one more question through the email, and that is, it sounds like both of your fellowships are very much focused on clinical, although they exposed to research. So if a fellow is interested in pursuing more research, either clinical research in the way of trials or translational, does your program give the opportunity to continue on for a second year?
Yeah, I've been asked that question quite several times actually over the last 2 years. I would say that we are flexible. If you do want to do research as a component of the fellowship, then what I would recommend is that you probably do a year of research with any number of our brain tumor center labs. We have 11 in that new building, and then several other labs throughout the campus. But I would say that first year you could do a postdoc potentially, and then the second year would be more clinical dominant. But that's something we could definitely talk about because a lot of applicants have asked me about that.
Yeah, I agree. We have a 1+1 option, but it has to be carefully conceived. This is such critical time for anyone coming out of residency. These years are gold, and you don't want to spend any more time somewhere than you absolutely need to. So it depends on the individual. The opportunity's there, and we have funding for it. But you want to make sure that if you're adding that year, that it's really going to change the face of your opportunities moving forward into your career.
Okay, wonderful. Thank you. Dr. Rodriguez and Dr. Zachariah, any additional questions that I've been missing here?
Yeah, I wanted to ask a question, and I did briefly disconnect earlier, so I apologize if this was the first question asked. But if the fellowship directors can just talk a little bit about some of the characteristics that they're looking for in an applicant. It seems like obviously Dr. Kim mentioned how competitive some of these fellowships can be, and people are contacting programs very early. But if there's anything that I know there's not a magic formula, but any certain characteristics or certain patterns of track record that junior residents can kind of think about to set them on the right path.
And I think we asked this question in a different format, so we're changing it a little bit. This time is, what would you advise to a candidate that is applying to you to show or to prepare as they're thinking about a career in neurosurgical oncology? So we're just differentiating from the very first question that we asked. And thank you, Dr. Rodriguez. So this is more like an advice.
I'll go first.
Yeah, go first.
I think you want to know what you're trying, why are you doing a fellowship? And, usually what I tell residents is, why do you need to do a fellowship? Because unless you feel like this is essential to your career, you should be well trained enough to go into practice. So for me, the fellowship is really an opportunity for individuals to really add another dimension to their career that will separate themselves from the competition, if you will, when you're looking for a position. There are other versions of fellowships. There are ones where your program may not have had adequate volume to really give you a heightened level of comfort, and so you need that additional exposure from somewhere. Our fellowship at the Barrow really isn't that, and so we're looking for those candidates that are already pretty comfortable with what they need to do and are really looking to, add an additional layer.
Yeah, I mean, I would agree with a lot of those things in terms of applicants we are looking for. I expect most of the folks that we see are going to be really reasonable surgeons already, really competent surgeons. So microsurgery is probably foundational. And then we want people who want to be leaders. So maybe they show excellence in some domain. You can't be good at everything, but you picked one or two things that you're really good at, and you can show that and demonstrate that, and then we can work with you on developing a vision for yourself for the future. That's sort of what we're looking for.
Thank you. And I'll take the opportunity to ask our two moderators tonight, Dr. Zachariah and Dr. Rodriguez. Why did you enter the field of neurosurgical oncology? What was the drawing force?
Yeah, I'll take that. I think very similar to what Nader and Kim had kind of elaborated on earlier, which is, I think what drew me to it was just really good mentorship with faculty who were tumor surgeons. It drew me clinically to that field, and I think what sustained me is really the patient interactions. I mean, I think that's really been one of the more satisfying kind of aspects of the job, working with the patients and their families and getting them through these super challenging situations. And there's just a tremendous amount of unknown, and that leaves the door open for just the remarkable work that they're doing at the Barrow, that they're doing at WashU, to really push the field forward. The incorporation of technology into the treatment of patients, all those things are fascinating, and that's really made it just a wonderful career, and kind of ultimately has proven to be the right choice. But
Thank you, Zach. Dr. Rodriguez?
Yes, I will echo the same thing. I think early on I loved the tumor cases were my favorite cases to scrub in on. And then I also really liked the research. I think they're very complex research questions that we still have not answered. But lastly, I think what confirmed it is the patient interactions. I usually tell people that sometimes I feel like the connections you have with your patients and um, oncology, you just cannot compare to anything else. You're usually the last person to operate on them in their life, and it's very a very special bond because you are doing everything possible to prolong their life so they can spend time with their family and friends. And that's just indescribable.
Thank you for sharing this. So as I mentioned before, tonight, the format is a little bit different. We did the Q&A session up front, and now we're going to do the presentation of the programs. Dr. Sinai, if you don't mind grabbing the screen and presenting your program.
Sure, of course. So, just like to load up. It really wouldn't be a talk from the Barrow if I didn't show you a bunch of operative videos all at once. But fundamentally, this is a clinically oriented neurosurgical oncology fellowship. We have high complexity cases that involve a variety of techniques, skull-based, non-skull-based, intrinsic, mapping, etc. And you will learn technically some nuances and details that will improve you and that are the product of years of technical refinement at this program. You will also learn decision-making and strategy, when not to operate, how to manage patients' expectations and the aftermath of an operation, as well as I've mentioned in the Q&A, the fundamentals of clinical trialing, of surgical trialing, and specifically of phase 0 and window of opportunity trialing. This is a one-year fellowship. It's CAST accredited. It's for graduates of U.S. Canadian neurosurgery residency program. When you're a fellow here, you are an attending neurosurgeon in Barrow Brain and Spine, which is the neurosurgical private practice. You are on service all year. You're serving as a cranial attending when you take call, which is about 1 to 2 days a month. We have 28 neurosurgery residents that are here to support you. As I mentioned, you are effectively a member of a private practice neurosurgery group of 33 neurosurgeons. So you kind of get insight into how that functions. The position itself has an RVU based compensation element to it. So productivity from call can improve your income. However, there's a healthy backstop provided by an endowment that really makes it unnecessary to be chasing cases, so to speak. You're really here to learn your craft. Applications are due annually on May 1st. We require a CV, an executive summary, references. We perform the interviews in person at AANS, and then informed decisions by SNO. The fellowship itself is really designed to fill what we think is an unmet need within this domain of neurosurgical education, which is preparing brain tumor neurosurgeons for a career either in private practice or academics or a hybrid thereof, but one that combines not just technical neurosurgical proficiency, not just really fundamental neuro-oncology care, but one that enables you to go to a program and build a clinical trials portfolio, really collaborate and lead other oncologists in drug development and use the operating room as a venue for surgical trialing itself. The Barrow itself is a high volume brain tumor center, over 1,200 brain tumor cases annually. This past year, 1,274. It is a mix of the typical mix of cases you'll see at a tertiary care high volume center. Intrinsic skull-based cases. We perform more phase 0 window of opportunity cases than probably any other program. We have a healthy mapping program and all of the other surgical adjuncts you'd imagine in a high level program. Fluorescence guided surgery, intraoperative MRI, laser ablation, et cetera. We perform some small set of outpatient brain tumor cases. Endoscopic and stereotactic radiosurgery are part of the education. The other part of the education is really working alongside 8 extremely proficient brain tumor surgeons, each of which have their own sets of expertise and each of which are really running dedicated brain tumor private practices in partnership with radiation oncologists, neuro-oncologists, and there is some time spent with Dr. Umamura and her team in clinical neuro-oncology because we want you to be proficient in the language of that field and in the habits of effective trial development. That also intersects with the IV Brain Tumor Center, which itself is a large dedicated drug development program for brain tumors, one that involves a lot of first-in-human studies, such as sonodynamic therapy, a lot of interventional studies, such as intraoperative Omayas for liquid biopsy. And as a fellow, you're a co-investigator on these studies, and in some cases, you can be a co-principal investigator. So we try to have you go through this, leaving with the toolkit to generate a program like this on your own, wherever you land. So with that, on behalf of my colleagues at the Barrow, I'll thank you again for the opportunity to share. And I appreciate it always from my colleagues.
Thank you so much. Dr. Kim, would you mind grabbing the screen and do your presentation?
Thanks again, Isabel, and thanks to Annalise and Brad. So I'm going to be talking about the Surgical Neuro-Oncology Fellowship at WashU, which is a relatively new fellowship. I run the program with Eric Luthard, who is the chief of the Division of Neurotechnology. So just some nuts and bolts. We are CAST accredited. This is a 1-year predominantly clinical fellowship. Applications come in by end of December, PGY 5-year, and then we interview you late spring, May and June, and come to a decision again by PGY 5-year. Oh, whoops. Sorry about that. You'll be able to work with a number of brain tumor faculty. Of course, myself, I do skull-based tumors and intrinsic tumors. Eric Luthard, he does intrinsic tumors as well as neurotech. Josh Dowling, he does intrinsic tumors as well as functional. Dimitris Mathios, he does intrinsic tumors as well. We just recruited Bhavik Patel, who's doing his fellowship with Paul Gardner and George Zanonos at UPMC. He'll be doing a lot of anterior skull base and some lateral skull base. And then our boss, Greg Zipfel, he does a lot of skull-based tumors. So you'll be able to work with all of these fantastic brain tumor surgeons, and also some of our vascular surgeons. They do meningiomas and other tumors. And this is Josh Osman, who's a vascular, and Anant Velamana. We do a variety of brain tumors of varying complexity. There are many complex brain tumors, of course. In terms of case diversity, we have over 600 open brain tumor cases per year, and we can break that into intrinsic brain tumors. We do classical awake, as well as other types of mapping. We have a leadership position in laser therapy. Eric Luthard, I think he did the first FDA-approved laser back in 2011, and right now we have over 500 laser therapies to date. We also do state-of-the-art brain mapping, and that's really led by Eric Luthard. As you know, he's done a lot of things with resting state, and to the point where we're actually doing a lot fewer awake mapping cases because of his resting state perioperative MRI. And then we have a number of trial protocols which you can be part of. In fact, we also have a phase 0 funding opportunity that, for instance, my fellow this year, Ryan Cleary, won, which is quite good. And it's a phase 0 trial looking at a cholesterol pathway regulatory drug. We also have skull-based tumors. You'll have anterior skull-based tumors through endoscopic and nasal approaches, something on the order of 170 or so last year. You'll have lateral skull-based tumors, for instance, vestibular schwannomas, CP angle meningiomas, other meningiomas, and of course, all of this is through multidisciplinary approaches, ENT, oculoplastics, and other folks. The basic schedule is a 3-month rotation system. So you'll do 3 months of intrinsic. And what we mean by that is you'll do more than 50% of those cases intrinsic for 3 months. And then you'll do a skull-based sort of heavy 3 months, and then you'll switch again. So you'll have 4 different blocks. You'll do a day of clinic per month with Dr. Luthart and myself. I think that's great for learning, not too onerous. And then you'll do chief call 1 weekend per month. And you also have academic time for research and, of course, job search. The other things that you have at your disposal are there's a skull-based lab, which we've been running for, I would say, over a decade now. I run 2 skull-based courses per year, again, over the last decade. One's anterolateral skull-based and the other is lateral. We have people coming in and acting as guest lecturers. We do lectures and then cadaveric dissections. And then you also have an opportunity to do your own dissections outside of those courses in between cases. You will also assist in running anterior and lateral skull-based conferences on a monthly basis. There's one anterior and one lateral once a month, and then you'll attend at least one meeting, a national meeting. These are the array of conferences that are available to you in terms of clinical conferences, the weekly neuro-oncology conference, the monthly anterior and then lateral skull-based conferences, as I mentioned, and then weekly residencies conference. In terms of mentorship, this is very important to Dr. Luthart and myself. We want you to develop a vision of your future that's very specific. Again, one that will distinguish yourself and add value to your future department. And we'll have regular meetings. We'll switch off between Eric and myself every 2 weeks at the beginning and then have more formal quarterly meetings in person. And then obviously we want to help you facilitate landing a position. Just so you know, we are relatively a new fellowship, but we are filled up for the next 4 years. So I think we hit the ground running. Now, in terms of research, again, it won't be the dominant part of what you do, but you have access to this for sure. And for instance, Ryan Cleary, our current fellow, is taking advantage of this. We have different programs at the Brain Tumor Center, which I direct, and which Alex Stegg is the scientific director of. So we have different programs, including convergence brain tumor science, and that includes things like LIT, FUS, neuroimaging, tumor biology, immunotherapy. Immunobiology is very strong at WashU, for instance, and then epigenetics along with the genetics department. Something that's also very unique, again, I mentioned that Eric Luthart runs a division of neurotechnology, which has a ton of faculty now. And their mission really is to not only create neurotechnologies, but also to translate them, for instance, that's led to sonobiopsy, and also to identify neurotechnologies if they didn't create them. And a great example of that is laser. And then finally to implement and deploy these neurotechnologies. And a good example of that is this resting state fMRI, which again, Dr. Luthart developed in his lab and we use on a daily basis clinically, but now he's trying to work with companies to bring that to everybody. WashU is in St. Louis. You'll be working in Barnes Jewish Hospital. You can see that on the upper left. Cancer Center on the bottom right. There's some really exciting new buildings that have come up recently. A new neuroscience building, the Fort Neuroscience building that just opened over the last 6 months. My lab is there with the other Brain Tumor Center labs. It's great space. The Ambulatory Cancer Center, which will enable more multidisciplinary care, is going to come up and open in fall of this year. That'll be really exciting. The fellow will certainly do some of his clinics in that building. And then things to do in St. Louis. I mean, we're known for barbecue, but it's not just like meat and stuff. And it's also other things, whatever you like, plant forward, sushi, vegan. And then we also have a large urban park. It's actually larger than Central Park, which I was surprised by, but it's true. And we have a great symphony, and St. Louis is obviously known for its jazz and blues. And thank you very much.
Yeah, that was great. And just wanted to thank Dr. Sinai and Dr. Kim for really giving us a nice inside look into their excellent fellowships. I think kind of really informational, and also getting to hear a little bit of their insight into kind of how they kind of ultimately chose their career in neurosurgical oncology. So we appreciate the time.
Thanks very much.
Thank you. Appreciate it.
Thank you, everybody, and thank you for joining us tonight. This was really great. Thank you for your time.
Bye-bye.
All right. Night, everyone.